Hi folks, my name is Ralph Mobbs. I'm a neurospine surgeon from Sydney, Australia. A huge thank you to the Virtual Global Spine Conference for putting on today's conference, and a big thank you to Mike Selby for putting the gig together, and my co-talker, Prof Ralph. So this is what we're talking about today. The progress and the evolution of design and my thoughts over time. So this is where I'm from. I'm from somewhere between the sharks and the giant spiders. That's Sydney. Now, the history of disc arthroplasty is really interesting. JFK had a Fernstrom ball inserted in the 1960s. We have here a shot from the mid-1980s. This is at the Charité Hospital in Germany. We have our patient here on the right side. Let's hope that she is pre-op, not post-op, because she's looking very drugged out on something. So, so there we have it, a bit of history for you. Now, this has been my evolution of cervical arthroplasty over the last, really the last 18 years. And the implants that I've used. And today I'll just give you a bit of an insight into why I've changed my pattern of usage of these implants over time, and where I'm going with the gig. So in the early years, the Prestige, I was a big user of the M6 for many years, the Mobi-C, and then finally my current go-to disc, which is the ESP-CP. So my practice, in private, I've done a little under 340 discs, and in the public about 80. So all up, I have an exposure to about 400, to over 400 disc arthroplasty. So I feel empowered to give you the nuts and bolts story of what I think has worked, why it's worked, and how my practice has changed. So in the early years, I used the Prestige. I'll tell you why, because it's what my boss used. And when your boss uses it, you get out and practice, and you tend to use it. The M6, which implanted a fairly large number of those over time. The Mobi-C, and more recently the ESP, and a bunch of other discs which I've used once or twice. So my workup for patients with neck pain, radiculopathy, less than 65, one level or dual level, my workup is that the patient has to have negative facet joints on a bone scan, relatively neutral sagittal balance, and motion at the index level on a flexion extension X-ray. And my post-op is that I use non-steroidals in an attempt to reduce the heterotopic ossification, which myself and my team have written a fair bit about over the years. I do place patients in a collar. That's purely because I'm paranoid that the implant is going to translate or move, which, mind you, I've actually never had happen in close to 20 years. I've never had a expulsion of a disc arthroplasty. I have had motion back and forth by 1 or 2 millimeters, but never an expulsion, and then return to full activities at about 3 months. So back in the early years, the Prestige, this is a ball and socket design, metal on metal. And I enjoyed putting this implant in. Here is one of the early patients that who received one of these implants. She was a ballerina. Her philosophy is that she wanted to keep on moving. I suppose you could anticipate that request from a patient. Here is an intraoperative shot, 2-level Prestige. Here is her at around about 9 months. We can see that her Prestige is actually moving quite nicely. She's getting an excellent range of motion there. However, this is 4 years down the track, and we can see that she has fused at both levels. At the 6-7 with heterotopic ossification posteriorly, and at 5-6, no motion on a flexion extension. Mind you, I didn't tell the patient that the implants had fused, as she was still very happy with her surgery and had the impression that they were still working. So don't tell a patient, if they're doing well, do not tell a patient that the implant is welded together. That's just my philosophy. As we all know, psychology plays a huge part in your recovery after any intervention. With the Prestige, I noticed that pretty much all of the implants had fused, somewhere between 3 to 5 years. So I thought, okay, I'm going to go to the other end of the spectrum and try and find an implant that will not undergo heterotoxic ossification and will provide excellent range of motion. And a new implant came on the market called the M6, viscoelastic core. I like the design. I probably read a bit of the marketing brochure as well and started using this implant. He was one of my surgical colleagues, a chap in his mid-50s. He's since retired. This was back in 2012, C5-6, the most common level for this particular operation, and exceptionally happy. This guy knows the literature on disc arthroplasty and refuses to have a post-operative X-ray, as he just doesn't want to know what's happened with it. He doesn't want to know if it's fused or if it's still moving. He doesn't care because he's still doing well. He was an ex-Olympian, an ex-Olympic swimmer. Mind you, he was 40 at the time. I placed a 2-level M6, did exceptionally well, and continues to do so to this day. As my interest in this implant started to grow, I started to get more gutsy in terms of the indications. Here's an adjacent segment disease following an ACDF that one of my senior colleagues sent me, a C6-7 adjacent segment. Discussed with the patient, ACDF, phragmotomy, et cetera, disc arthroplasty with leaving the plate, disc arthroplasty taking the plate out, et cetera. So a decision was made to remove the plate. I find that removing the plate helps with the positioning of the TDR as well. And it looks nicer on a post-operative X-ray. And so this is that patient post-op, and he's doing very well. Here's an intraoperative view of the plate being removed, midline positioning of the M6, midline positioning tool, decompression, making sure that everything is nice and clean. A trial with the cutter for the keels, and insertion of the prosthesis. I was a big fan of this prosthesis for a number of years until I had a cohort of patients coming back at around about the 4 to 5 year time period. And I'll give you an example of one of these cases. Here's a young chap who I implanted a M6, operation date 2014. Looks well positioned on the X-rays. This is him 5 years down the track. And I'm sure that you can agree that something doesn't look right here. The patient stated that his neck pain was progressively worsening over about a year, that he would have this incessant clicking in his neck whenever he went into a flexion, and he just wasn't happy. His arm pain hadn't returned, but his neck pain was definitely getting a lot worse. This is about 5 years post-op. I'm sure that we can all agree that the intraoperative compared to the 5-year post-op X-rays looks very different. There is significant loss of the disc height, and there is greater than what you would expect translation of the implant inflection, quite a concerning X-ray. I sent the patient off for a CT scan, which confirmed that something wasn't quite right. We have significant osteolysis in the adjacent end plates, and loss of disc height to pretty much bone on bone there. This is a sagittal view of the same patient, and again confirming the clinical concerns and the radiological concerns on the flexion extension study. He required a revision to an ACDF. So let's just go through some of the intraoperative pictures of this particular patient, and my concerns, and the reason why I'd moved on from this implant, as this has happened on several occasions. So firstly, the external core of the implant, you can see it, the plastic, the annulus had extruded completely anterior to the implant. All the blackness that you see in this shot is not a diathermy burn. It is something to do with the implant. It's probably wear particles from the titanium rubbing on the titanium. Here is exposure of the implant. We can see that there's really nothing inside the disc prosthesis. On distraction of the prosthesis, we can see that there's essentially an empty internal space. Now, is this the video? No, here we go. So let's have a look at the relative mobility. This is distraction of the Caspar pins. We can see on the inside of the implant that it's empty, and this is a kerrison just to assess what the degree of stability is of this motion segment, and we can see that it's highly mobile. So we have a problem here. Essentially, the entire viscoelastic core has degraded, has extruded with wear particles from not only from the viscoelastic material, but also the titanium on titanium and with osteolysis of the surrounding end plates. So here's a sequence of events. A, the initial post-op. B is the flexion extension some years down the track. D is the CT. E is the intraoperative findings, and F, and then G, finally, the revision. Now, after several of these cases, all at a fairly similar time frame, at around about 4 to 5 years. So this failure would not have been captured by the IDE studies that had completed at 2 years. So sure, my patients were doing very well at 2 years, very happy. And then a few years after that, we're starting to see the problem. So I made a decision one day, that's it, no more. So I moved to, from a viscoelastic design back to more of a ball and socket. But this is a sliding core design. This is the Mobi-C. I planted a number of Mobi-Cs, but unfortunately, for a number of patients, I ran into similar issues, not in terms of degradation of the viscoelastic core, but hypermobility as an inherent design feature of the implant. Here's a patient in her 50s. She had a great relief with her radiculopathy, but within around about 15 months of her surgery, she had this incessant problem. She would bend her neck forward, it would click, her neck would get stuck in a position, then they'd have to click it back, and then she could go back into extension. Clearly, she couldn't continue with that symptom, so that needed revision. Another patient, again, this is at around about 12 to 15 months post-op. Excellent relief of the radiculopathy related to the posterolateral disc herniation. But this patient complained of annoying, worsening interscapular pain, quite a similar pain to what we see in patients post-ACDF when we distract the facet joints significantly. So my philosophy is that the patient was getting really bad facetogenic pain in extension when the facet joints would clamp together and significant loading of the facet joints in extension. So here we have a design that's now failing by virtue of its hypermobility and failing in extension with crimping of the facets and flexion with a partial subluxation of the facets, causing this annoying clicking and locking of the neck. So back to the drawing board. I'm now at sort of 13, 14 years I've been using disc arthroplasty. A bunch of patients super happy with the early postoperative results, but failure either of fusion of the construct, failure of the viscoelastic core, and now failure of hypermobility of that as an inherent design issue. So back to, where to from here? Do I now give up on disc arthroplasty and do I go back to fusion? And that's a serious question that I was asking myself. I did some research and I came across this implant. This is the ESP-C from a company, Spinal Innovations. So the reason that attracted me towards this implant is because it moves, but it doesn't move as much as the hypermobile implant. So perhaps are we looking at the wrong thing? Are we trying to get too much movement with arthroplasty? Are we missing the point? Should we be looking for motion but as we age and as we stiffen up and as our range of motion decreases, are we looking for motion, but a little bit less motion? So I transitioned to this implant. I must say the relative early results I've been using it for several years now. I haven't run into any early stage. However, I haven't been using it for that 5+ year time bracket to establish whether or not the viscoelastic core will run into problems. With arthroplasty procedures, one of the common usage patterns is as a hybrid procedure. My preference is to use an integral fixation device as part of the hybrid. And whether or not that's a 2-level or a multi-level, I do like to use the motion sparing implant at the top end of the hybrid construct. So this is the evolution on using these implants, pretty much since when I first got out into practice in my early 30s, over a close to 20-year time period, is that I'm now convinced that we're looking for motion, but not too much motion. Myself and some colleagues are putting together some data on the kinematics of the various implants. And interestingly, we've found that the M6, this is at a minimum of 2 years. The M6 at 5, 6 and C6, 7, 8 degrees plus or minus about 4.5 degrees, fairly physiological range of motion. But unfortunately, a late failure of the viscoelastic core. The Mobi-C, by far the hypermobile design, 11 degrees flexion extension plus or minus about 5 degrees. Yeah, that's a lot. That is a lot of motion for a single level. The ESP, and I suppose what I really do like about this implant is that it moves, it maintains motion, but it's a stiffer design. And will this translate into a reduced risk of complications and failure of the viscoelastic core? I'm certainly hoping so. So there we have it, folks. That's that's the thoughts of a surgeon who's put in close to 450 disc replacements over an extended time period, and who keeps good long-term data on a lot of these implants, or at least the ones that I can follow up on. And I'm sure that before the end of my career, that this talk will even morph even further and further as our understanding of what we need as we age in the neck, and our understanding of the of what does and doesn't work with cervical arthroplasty. Thank you very much, and thanks again to the Virtual Spine Global Spine Conference, Mike Selby, Prashant, and the full team. Thank you, folks, and I'll take any questions. Okay, there's a couple of questions that are coming up. Why do you hate anterior plate? Okay, well, thank you. I'm not a big fan of anterior plates in the neck. Additional dissection, more fiddle factor, integral fixation devices. You can limit the dissection, you can limit how much exposure that you do. And also, and I suppose most importantly, is that there's some really good evidence now to show that anterior plates, actually, there's a lot of negatives with them, not just the obvious stuff of esophageal problems, but also that the closer that a plate is to the adjacent segment mobile disc, the higher the rate of adjacent segment degeneration. So in my own practice, I haven't used an anterior plate for years, and I'm not going back there. Thanks. Another question. Will discs in the neck become like hips and knees? Will all the designs essentially look the same? Okay. Well, I'm a neurosurgeon. I'm not an orthopedic surgeon. I haven't done hip and knee replacements. So I'm probably not the best person to ask that. I know that Mike Selby's on. Mike Selby can probably add a bit of his words of wisdom there. Well, yeah, that's a good question. I don't know. I mean, at the moment, we have such a diverse range of designs with cervical arthroplasty, and that tells me something. And that tells me that no one design is the best design. We don't even know if what's better, you know, a ball and socket versus a mobile core versus a viscoelastic. We don't know. And even beyond that, we don't know what is the best design pending a particular age bracket. Should we be putting in more mobile designs into younger patients? Should we be putting in stiffer implants into older patients there where, for such as that lady that I showed, where she went into flexion and her facet joints almost dislocated in flexion due to the hypermobility of the Mobi-C. I mean, there's so many unanswered questions with cervical arthroplasty. And all I can really say is that watch this space. Okay, one more question, and then we better go to Prajanth. Does infection cause wearing out of discs? Okay. I might get Prajanth to answer that one. Just to very briefly say, myself and Prajanth started the Australian disc study back in 2013, following that following that paper, the European paper on the use of antibiotics and back pain, which for a lot of us, we looked at that paper and thought, you know, it doesn't, you know, if it looks too good to be true, it probably is. And the results of the disc trial really do highlight that. We looked at close to 800 discs here in Australia, both degenerate, non-degenerate, and sham, and we tested a lot of them. And if I can give you my summary statement in a single line, I can confirm for you that disc degeneration does not occur from infection. It occurs probably from genetics, and it may be related to your date of birth as well. Who knows? Yeah. Hey, folks, I think that I've gone over time. So, Mike, thanks, mate. And Prajanth, over to you. Bye for now.